Okay, let's see. It's working.
It's working.
It's working.
Alrighty, you guys. So, again, I'm Professor Hernandez. If you guys ever need me throughout your semester, it doesn't matter if I have you guys or not, just get a hold of me. We can go over test taking strategies. That's usually my thing. Only because I'm not a very good test taker. I failed my NCLEX the first time because I freaked the F out. Okay. My nurse practitioner, same thing, didn't pass the first time a bit because I'm just a really bad test taker. I have really bad functional anxiety. So I had to learn all of these different tactics in order to be able to be successful in these type of exams. And then of course, you guys already know this being at the end, is that when you guys study for a regular exam coming out of like high school or a different type of degree plan, nursing, you got to revamp everything in order to be able to kind of adapt. Okay. So, but like I said, get a hold of me. I'm more than happy to help you guys. I am teaching MedSurg 2 and Psych this semester, so I'm done with Psych. I'm just grading for them, but I have MedSurg 2 rotation too. That's my only thing after that. So if you guys need anything, like I said, let me know. So my background, I've practically done everything in the last 20 years. Okay, so I'm not old, but I've been a nurse since I was like early 20s or so. I have my 15-year-old son. What's that? You're not old either. You're as old as you feel, although I feel old today. I've been a nurse 16 years. No.
I know.
It goes by super fast, I will tell you that. Yeah. But I've been in healthcare since about 20 years or so, from pharmacy to I can read heart monitors like nothing. So I've done everything up to also med surg, ICU, leadership, hospice, case management, pediatrics. I also do pediatric nurse practitioner as well. So again, I've done everything. My strengths are cardiovascular, like cardiac stuff. That's my thing. I just recently went into nephrology and I just made the decision to go back for my doctorate's degree, but I'm going to do a double certification in acute care adult gerontology. So there's probably anything that I probably don't know, or I at least know a little bit about everything. But if I don't know, I always know where to go as far as to find the answer. Okay. So in saying that, when I usually lecture, I used to teach MedSurg too. But when I usually lecture, I like kind of feedback back and forth. Okay. I think I have 3 or 4 of these to do. So I'm going to go kind of quickly with this because again, this is review. So as I ask you guys a question, I would expect for you guys to kind of give me the answer, okay? All right, so let's start off with the cardiovascular assessment stuff. Let's see. Okay, so obviously when it comes to cardiovascular, we're talking about pain, right? Chest pain is the ultimate sign that something is, going on in that area. So you need to know the different sites of pain. So if I say epigastric pain, where is that? Right in the center of the stomach, right? If I say precordial pain, what do I mean? In the heart, actually in the core, right? Right in the core. So right there. Is your heart on the left side, right side, in the middle? A little to the left, right? And it's actually sectioned to where the apex is what? This way, right? To the right. So it's pointed to the right, okay? So kind of know, if you know the structure of the heart, you'll be fine. So this is definitely important to know because whenever you document, right, because it's all about documentation, okay? When you document and the patient comes in and they say, oh, it's right here, you're not going to say, oh, the patient just pointed to, the middle of their breastbone. You're not going to say that, right? You're going to say it's epigastric. So things like that, okay? Or sternal. All right, so normally in a male, because chest pain is different in a female and in a male, okay? So in a male, they'll typically feel it right in the middle of their chest pain, substernal or sternal, okay? The pain usually will radiate to their left side and up their jaw. Whereas in a female, their pain is usually in the middle of their back, okay? Right in between their shoulder blades. So every day in and day out, because I have a bad back, I'm always thinking I'm having a heart attack every day, okay? But yes, I consider myself a young nurse, but in my day still too, we didn't have all the fancy equipment that you guys are blessed with now. So when we lifted 800-pound patients, it was 4 of us, my size, with a white sheet. or a couple in case one of them ripped, right? You guys have all these extra fancy things, so hopefully you guys don't get bad back. So in that, lift up your bed, please, all right, to save the rest of your back. So again, I wake up every day with back pain, and usually I'm like, oh, I'm gonna die of a heart attack today, okay? Hopefully not. Try to keep my stress level down. All right, but just learn these things so that way you know. But again, in your back is usually where the females have their pain. Why do you think that is?
Smaller muscle mass.
Smaller muscle mass, definitely, right? Most females have pretty much a good, strong back. However, we do have all of this in front that usually would kind of might mimic different types of pain throughout different times of the month, right? Okay, so usually the muscle mass, perfect, very good. Okay, so when we want to do our cardiovascular assessment, we want to make sure that we're doing everything. Now, you guys, I usually don't kind of read through this, so kind of bear with me, okay? Now, you want to make sure that it all starts with inspection, right? Is the patient looking at them? Normally, you can see the jugular vein distension. Are we distended? Are we, pulsating, right? There's times when I look at my husband while he's asleep and I see some pulsating, and he's not the healthiest right now. Trying to get him there. And I'm like, oh gosh, right? And so I'm just watching and watching. I look like a little crazy person at nighttime watching him sleep. But it's part of your assessment. You're taking a look. That's the most obvious thing, right? Because when we talk to each other, we're looking eye to eye, and then you can kind of gaze with your peripheral vision what they look like. Color, right? Color makes a huge deal, specifically of the skin, because normally when we have heart failure, we're sometimes a little bit ashen gray. Hopefully we're not blue, right? If we're blue in heart failure, that means that we're in an exacerbated state, okay? We want to go ahead and also auscultate. We're auscultating for heart tones. Know your locations, right? Aortic, pulmonic, Erb's point, where we mostly hear what? Murmurs, right? Most common place to hear murmurs. And then tricuspid, mitral, right? The mitral valve is also called the what, where we palpate? Apical pulse, very good, very good. Okay, that's actually one of, like, it's on the test somewhere. I think it's this semester, so just saying. All right, so if we feel a thrill at the mitral valve, if we feel one, palpate it, that is your apical pulse. That is a common finding, okay? That's a common finding. All right, and then, so you're also gonna be auscultating what on the carotids? What are you auscultating for on the carotids?
Like the same
A bruit, right? We're auscultating to see if there's a bruit or not. So you need to turn your stethoscope around to the bell part, right? Not the diaphragm, which is the biggest part. You go to the bell part so you can you can try to hear for those things, okay? Very good. Okay. And then, so that's inspection, auscultation. On palpation, what else are we going to palpate for when we do a cardiovascular assessment? And think of cardiovascular.
edema.
We can palpate for edema, okay. Pulses, right, pulses. And when we document those, edema and pulses, they're graded and they're also documented with words, right? So +2 is usually within normal limits, okay? I don't like the word normal, so I go with paint me the picture. You got to tell me what it is, right? Regular or irregular pulses, right? Because that makes a huge difference, okay? And then edema, how do we grade edema? +1, +2, +3, +4, pitting, non-pitting, right? Dependent edema, dependent meaning more general, right? At the end of my day, because I'm on my feet 24/7, I have generalized edema, right? Okay, so usually all of us do. If that edema goes away by morning, then you're not in heart failure or kidney disease. If it still stays there, we have a problem and we need to probably see a specialist, okay? All right, everyone's gonna go see a specialist and be like, oh my God. Okay, and then we're auscultating for S1 and S2, normal, correct? Right? S3s? I don't know about, what is that? And in what? More specifically?
Isn't it for kids? Like
Not kids. Pregnancy. You're going to find that most commonly in pregnancy, right? More so because of that big old belly full of baby is pressing up on the thoracic cavity. Make sense? Okay? All right. Don't go too much into detail as far as like the skinny and, the kiddo, whatever, because that won't be on your NCLEX. What might be on your NCLEX is the pregnancy, because it's the most common time that you will find a new murmur. Okay? All right, very good. Okay, so we went over this as far as the traditional areas where you're going to auscultate. So again, know that. All right, and then when we're looking at the vascular system, on top of looking for edema, right, your pulses, you're looking for the varicosities. Varicosities meaning varicose veins, right? We're looking for hair distribution. Why are we looking for varicose veins and hair distribution specifically? What disease processes? Peripheral artery disease, PVD, right? Circulatory problems, right? We have that everywhere. What is the most common cause of those circulatory problems? Smoking. Smoking and sedentary lifestyle, right? If I don't exercise those vessels in my legs and my arteries in my legs, then it's just gonna get really lazy, right? They get really lazy. What do they usually contract on the inside? What usually builds up on the inside if I get really lazy? Atherosclerosis, right? So you're going to get all this buildup, high cholesterol. Okay. All right. Very good. Now, when we look at the hair distribution and everything, we're looking for temperature, any types of lesions that might be happening. You're looking to see if you can distinguish between PAD and PVD. Okay. PAD, if we have ulcers, what do those usually look like? Red, beefy, they don't heal at all, right? And then if we have PVD, you have those varicose veins that get super swollen with all this fluid because we're not exercising them. If we don't exercise, fluid stays, right? Okay. So we then have all this fluid surrounding those veins, and it brings them up to the top. Well, those don't belong at the top. That's why they get super painful, right? If one of those bursts, usually you have differences. It's not that beefy red type of thing. They get hot, right? Very painful, lots of neuropathy. Make sense? Okay. So know the differences on how to make sure that you can distinguish one and the other. All right. We also look for clubbing. So now you can see clubbing in a different diagnosis that is respiratory. Which one? Not COPD, more specifically, pulmonary, starts with an F, ends with cis. Fibrosis, right? Pulmonary fibrosis, all right? The reason why I point that one out is because that is a pediatric disease, usually, and that goes into adulthood, and you may see that one on your NCLEX. Again, I'm trying to focus you guys in, okay? All right, very good. So you're looking for clubbing, right? So that literally looks, have you guys ever seen, what is it called? Oh, I forgot. ET, yeah. ET, right? So pretty much think of his hands. That's what they look like. It's very unfortunate, right? Very unfortunate. Oh, sorry.
Children with cyanotic heart defects.
Correct.
Those they correct them, they do those corrections in stages, and so they go for a long time with O2 sats in like the 70s.
Mm-hmm. Yep, definitely. Definitely. Always with blue purse lips and everything. When they first developed cabbages, right, open heart surgeries, they found it more so in your neonatals, in your babies, right? And whenever they would feed, they would turn completely blue. And that's how they first started developing or researching in ways of being able to correct certain congenital defects, heart defects, okay? All right. Okay, so we know how to palpate. You guys know the different parts that we should be palpating, popliteal, dorsalis pedis, those types of sites, okay? All right, and whenever, something I always tell students, because I've also done trauma as well, when you guys have a broken limb, right, we should always be checking pulses at the distal and proximal. So if I have a broken ulna, right, or radius, radial pulse, and a what? Brachial pulse, right? Brachial pulse. So you always want to check in front and behind. Okay, very good. Okay, this goes over PVD and everything. What is the diagnostic imaging resource that we have available to check also for those pulses that maybe we can't feel? Dopplers. Use your Dopplers, okay? And then, of course, you have Doppler ultrasounds as well. I always do that. It's because these are pre-recorded too. Let's see. Okay, then we look at the arms. We want to palpate as well. Now, for the kiddos, for babies, what is the site to check their pulse?
Oh, and like
brachial, right? For the kiddos, you check them brachially, right? So, because it's more centralized to them, okay? So if I have a pulse in an adult, if I have a pulse at the radius, what's my systolic blood pressure?
Good enough to get to your hands.
Which is what? What's adequate? Not 120,
What? 100.
90, right? That's a 90 SBP. I was also an EMT. So whenever we were out in the field, that was in high school too. I started early. So, and again, I'm not old, guys. I'm like, I forgot what I'm old. I'm 43. Yeah, 43. So 90, at least 90. It's at least 90, okay? So whenever we have a patient that goes down into cardiac arrest, right? We always check which pulses and more carotid, right? Carotid more specifically initially, because we want to make sure that we're at least perfusing to the brain. Okay, main source. This is the main thing. Without this, we don't do anything at all, right? If we can't find one carotid because of all the chest compressions, because we're so busy up here when we're trying to do CPR, then we'll check for a femoral pulse because it's the closest to the core. If the closest to the core is getting plenty of circulation, then I should have a good survival rate, right? I'm not going to check for a radial pulse, not going to check for a DP pulse, because I know for sure I'm not circulating all the way out there. All right, we can live without fingers and toes, okay? Alrighty, so we're checking for cap refill. What's your normal cap refill? Less than 2 seconds, right? Oh my gosh, I always do this. Sorry. Oh my gosh. Okay, I'm gonna leave that thing alone. Okay, sorry, I always do that. I need to figure out how to disable that. Okay, so yeah, now we're awake. Everybody on the same floor already got all of the presentation. Okay, so again, you're looking for edema, you're looking for sensation. What am I looking for when I say sensation? There. When I'm assessing for sensation of the legs. Paresthesia, yes, paresthesia, because without any good circulation, my nerves are going to either become paralyzed and eventually die. Nerves do regenerate. I keep hearing people tell other students that they do not regenerate. And I'm like, where did you hear that? They do regenerate, but very slowly. Very, very slowly, okay? It might take years for them to regenerate, but they do, okay? So as we can continue with good circulation, then we can definitely get them to kind of pep up, all right? Okay? I'm afraid to press the button. Let's see. Okay, all right, so looking for arterial and venous insufficiency, we have something in the, we do ABIs, right? So we measure the CAV, and we'll do some testing just to see what kind of arterial and venous pressure we have. So if you have a patient, I work in clinic, but if you have a patient out in the hospitals, you don't necessarily see this test go on quite a bit, but if you guys were ever to be doing like any type of clinic nursing or anything like that, you guys would be the ones to be doing the tests for the providers, okay? So, but it measures arterial and venous insufficiency, and it gives us a score. And that'll tell us if the patient either has it or they don't, or they're getting there. And usually if the patient's a smoker, they buy themselves this test, okay? Because we check anyway, just in case. All right. Okay, so big thing that I'm a huge stickler for when it came to my CJMs and MedSurg too, is that when you tell me a patient is in pain, you gotta tell me all of the other details about it, okay? When did it start? What makes it better, right? What were you doing when it happened? Where does it hurt? What does it feel like, okay? How long has it lasted? How long have you had it, right? How bad is it, right? So all of PQRST, right? We don't necessarily do too much in this program with cold spell, but it's similar. It's very similar. It's just an older one. And then of course, ISPAR. I changed that actually because I'm a provider and I would always get calls and I'm like, that's nice. You've already presented everything nice and beautifully as an SBAR. But as far as your introduction, I didn't know who you were, what patient you were calling about, what hospital you're calling me from, because I usually service all of them. right? So be very particular when it comes to the introduction part. It sets your basis, your precedents, okay? All right, very good. Okay, let's see. All right, questions on assessment? God bless you. All right, okay, so let's go to high blood pressure, right? Silent killer over here. What is blood pressure? We want to make sure that we're measuring both systolic and diastolic measures of blood pressure. What is systolic blood pressure? What is it measuring? The strong, okay. Give me more. What part of the heart is pumping?
Left side.
The left, which side? Oh, left side, but which pump? Ventricular side, and where are we pumping to? But okay, aorta to the what? To the rest of the body. There we go. I see it now. Y'all are describing it, okay? You guys need to know to describe it, because whenever I say, well, what is systolic blood pressure? Well, tell me what it is in the body. What does it look like? Because then I know that you know what you're talking about, okay? What about diastolic? What is that measuring? Give me more. Filling of the heart during what period? Relaxation period, resting period. Very good. Do you see it? Okay. All right. If I would have had you, y'all would have been artists by now. All right. Okay. So it's good to know those two things. So now you know what the heart is doing, right? Not saying that the other chambers of the heart aren't responsible for whatever, but the left ventricle is the big one, right? It's the most muscular one. Now, when it works too hard, right, because of different types of conditions, then it gets really huge, and then we have too much of a muscle, right? What happens when we get big old bodybuilders? Are they very flexible? No, they walk like this all the time. Can you imagine? Right? Okay, they're not flexible at all. It's like I tell my son, he's trying to bulk up, and I'm like, son, you also need to stretch because you're a baseball catcher and they're very flexible. But if you're going to bulk up, you're going to stay that way, and your response time is going to be a lot shorter, right? It's going to be a delayed response time. Same thing about the heart, right? So we don't want them to be, we want them to be strong, the left ventricle, but we don't want them to be overly built. Okay, make sense? Yes? All right, perfect. Okay, so normal blood pressure in your textbooks always say 120/80, okay? But we also have a normal blood pressure 130/85 now. So those standards are changing. Your exams will be traditional, all right? Exams in probably 2 more years, NCLEX exams will show new numbers, okay? Normal blood pressure for a patient in chronic kidney disease is 135/90. Okay, if we have a patient that has high blood pressure, it's usually over 140/90, and then of course those are staged. We have stage 1, 2, 3, 4 of different blood pressures, okay? You don't need to know those specifics for NCLEX, but do know what your normal is, all right? Okay. Okay, then how do I know I have high blood pressure? What are some common symptoms? And it tells you up there, cheats for you. What are some common symptoms all the time that you hear from a patient that may not even know they have high blood pressure, but then all of a sudden I'm diagnosing them with it? A headache. What else? Blurry vision. Definitely. What else? And it's a headache that doesn't go away despite what I do. Okay. What else? Some people get ringing in the ears. They get tinnitus, right? They get tinnitus. It's all that extra pressure. And then the frequent urination at nighttime. Why do you think that is? Not sugar, although that is part of it, but not in this lecture. We'll do that one next time. Because when we have high blood pressure, we retain fluid, right? So when you're relaxed, you're asleep, right? So your body's going to say, oh, this is a good time for me to get rid of this fluid because I'm nice and relaxed. My blood pressure is lower. So you're getting up all the time to go pee. Okay, make sense? All right. All right. And then when we have all that fluid retention, what is the primary reason we have all that fluid retention? Because of your high blood pressure. What goes along? Think of diet. High sodium diet, right? Because as soon as you become a heart patient, what do I tell you? Go eat cardboard, right? Go eat cardboard, low sodium, because how do we kill a weed in your garden? If you have a weed in your garden, how do we without you having to go buy those expensive chemicals? You put salt on it. You put salt on it, right? You have a weed coming out in your driveway in between the cement. What do? You put salt on it. It draws out water. Water follows salt. Okay? So we always tell the patient, decrease your your sodium intake. What kinds of foods have high sodium? Processed food, canned goods, right? Processed meats. What is processed meats? Deli meats, your bologna, your ham, your turkey. So when you guys are educating your patients, you need to tell them all the way down to the nitty gritty, not saying, oh, keep a low sodium diet. Oh, I don't know what sodium is, but okay, I'll just keep what I'm doing, right? Because they don't know any better. Low salt. Well, what are low salt are things? If you eat out of the freezer and where it's easy and convenient for you to put it into your microwave and you have dinner in like 2 minutes, it's processed in salt, right? That's how it lasts so long in your freezer, right? It's cured in salt. So you always want to just make sure you bring it down to their level. Not saying that they're, beneath you or anything, but you guys know medical. Before you guys started, y'all knew that ham, cheese has salts, right? Anything processed has salt, okay? Pickles, don't go eat lots of pickles. All right, so we use a sphygmomanometer to do your blood pressure management. Now, huge thing on that is to make sure you have the right size, have the right cuff size, okay? Because if not, you're not going to get an accurate reading. All right, this is what I was talking about whenever we have optimal, normal, and high normal on how often we're checking in a clinic setting. So unless you're going to become a cardiovascular nurse, then I would suggest then you know these things. All right. What kinds of things cause high blood pressure? Smoking for sure. Stress, unfortunately. Caffeine, right? I am not a supporter of Monsters. I'm not a supporter of energy drinks, right? Every time that I lectured for MedSearch 2, and if I saw one, I took it from you and I threw it out in front of you. Don't like it. We have young people, younger than you guys, that are going into heart failure because of those drinks. Okay, Celsius is another one. Have you guys ever checked the normal consumption of caffeine you're supposed to have in a day? It's 65, okay, 65, 1 4-ounce cup of coffee. And how much is in your Celsius? Exactly, exactly, okay? And then some people drink 4 or 5 of those a day. Insane, okay? So, just saying, all right? So what organ is responsible for blood pressure regulation? The kidneys, right? Your RAS system. So, your kidneys. So if we have kidney problems, your blood pressure might be a little bit wonky, right? More than likely it's going to be high. Some of my patients do have low blood pressure just because of their kidneys, okay? All right. And then of course, narrowing of the arteries. So like if we have high cholesterol, right? PAD, PVD, we're going to have issues with our blood pressure. Rare tumors, you said the adrenal tumors for specifically are ones that will make your blood pressure go out of whack, okay? And then of course, darn that pregnancy. It's a good thing I don't teach OB because I would have lots to say about that, right? All right, okay, so pregnancy, I mean, you guys don't know encyclopedia, your encyclopedia is Google. But if you were to Google, pregnancy is a parasitic process, right? God bless you. So it's a parasitic process, right? It's something that's living off of a host. And then even so after, okay? So, all right. My son's ears always are like, oh, you're gonna lecture? My ears are gonna be burning today, Mom. My husband too. They know I talk about them. Okay, so controllable risk factors, making sure that we keep the salt down in our diet, right? We keep a hopefully healthy stature, right? Okay, I have patients that come into clinic and they're like, I feel so much better. You'd think you lost 50 pounds. Yay, right? So, I mean, it's all about the stature, right? Alcohol, stress, and of course, lack of exercise. Now, I don't know how to exercise. I don't like it. I'll walk, and that's the most you're going to get out of me. I don't do stairs. You can ask her. I said, I'll meet you up there. I take the elevator, but also because I have really bad knees. I just jack myself up, so it's okay. But if I were to exercise a little bit more, I probably wouldn't feel like I was having a heart attack every day that I woke up, right? Okay. All right. Okay. And then, of course, the uncontrollable stuff. Your genes, right? I have lots of patients, I tell them, I said, hey, you're like my husband. My husband was boxing at the time. He was already like he was early 30s. So it's called Gold Gloves and Geriatric. He didn't like that. But he was in his early 30s. His weight looked great. He was just straight out of the army as well, doing, 3 tours in Iraq. So, and didn't have to take any medication or anything like that. If anything, he had broken bones and stuff from the army, from injuries. And then all of a sudden he gets really sick. I'm gonna have him in the hospital and he had 2 mini strokes. Didn't know that he had hypercholesterolemia, right? But then I didn't think about it because my father-in-law had already had 2 heart attacks before the age of 55. Okay. I have a patient that I just diagnosed Monday with right-sided heart failure, and she's 37, and her sister just had triple bypass at the age of 43. So I sent her to the hospital. I did an EKG, and I'm like, you're going to the hospital. She wasn't having a heart attack, but something else was happening. Okay. So I was like, I'm pretty sure, let's go to the hospital. So again, it's all in the gene, and she's tiny. She's tiny. Doesn't have high cholesterol at all, but something else is happening, right? Something cardiovascular is happening. All right, so, and then of course race, right? So normally it used to be that, 1 out of 3 African Americans, but now we're seeing a higher incidence in Hispanics, okay? So African Americans and Hispanic cultures is what we usually have high blood pressure, okay? And again, they could be all types of healthy and normal, but it's in their genes that they have high blood pressure. I have an African American male that I think he's 33, 34, and he's in chronic kidney disease stage 3B. No, and all because of his blood pressure. Okay, all because of his blood pressure. So now I'm watching him closely almost every 3 months. I say, we're gonna get to be really good friends because I'm gonna bring you in every 3 months now. Okay, all right. And then, of course, women in high blood pressure, you're looking at those contraceptives, right? That put you at risk for blood clots, right? Blood clots. So I just recently had a friend that is on her depot, and she is 37, single mom. She's been on depot already for 2 years, okay? But she's always been on the pill before that. So, and she just went into the hospital with a PE. Okay, so abruptly. So just be very careful. Contraceptives, yes, are good. But anything that you put into your body, there are side effects to it. So if you can abstain or even count your days, ladies, from, trying not to get pregnant, right? Then do that as well. But there are lots of side effects to your medications, and that is one major one. It tells you everywhere, okay? Being overweight, after menopause, and then of course, African American descent, okay? That darn menopause, I'm getting there. I'm actually waiting for it. I'm good with not having the monthly thing. I'm good. I'm okay. I only have my 1 kid, and that was enough for me because he's expensive. All right, okay. And then how does high blood pressure develop? Do y'all know the whole patho of that, right? The vessels, how they're constricting. I always say, I always give my patients this type of scenario, okay? We have what's called the South Texas Special in my book. Diabetes, high blood pressure, high cholesterol, okay? There you go, I love it. Although that cocktail is all in the valley and everything, okay? So, your arteries and veins are like a garden hose. When you buy it from the store, it's nice and flexible, right? It's clean on the inside. Okay, once you leave it out in the sun being diabetes, right? Diabetes causes what? Atherosclerosis. That water hose starts becoming very stiff, okay, right? Whenever I put it to, before I put it to the water hose, right? And then I'm gonna go give water to the flowers. So when it's nice and clean, whatever goes in comes out. They get plenty of oxygen, plenty of water, plenty of food, right? Okay. Now that I've had the water hose outside, it's gotten stiff because of the sun, lots of sugar, right? Glucose, okay? All right, Now, same source, but now all of a sudden I have stuff, grime, icky stuff on the inside. What is that? Plaque, cholesterol, buildup, right? Now that orifice is this smaller versus big and wide like it first started off, right? Okay, so now I have the same water pressure coming from the left ventricle, same water pressure, but now I'm meeting resistance, right? High blood pressure. And then what do I have trickling now? Barely any water, okay? And when my flower bed doesn't get enough oxygen or water, what happens to it? It starts to wilt, right? Neuropathy, low circulation. Make sense? Okay. So be cognizant whenever you guys put another barbacoa taco in your mouth. Okay. And then drink it with some coffee. All right. Okay. What kinds of things can this do to my body, right? Stroke, huge one. Okay. That's a blood clot to the brain. Easy, right? Congestive heart failure, right? That pump starts to not pump as good. So now everything's building up, right? Kidney failure, we talked about that one. Heart attack, what's a heart attack? Well, I know that. I know abbreviations, but what does it look like?
Arteries clogged from the heart.
Which arteries? Coronary arteries, okay? You'd be surprised how many times once we get to this level, I'm like, what is it? They're like, oh, coronary artery, but what is it? What did they do during the procedure? I'm not asking for abbreviations, right? I want to know what they did. Can you see the procedure? God bless you. Okay, heart rhythm problems. More specifically, which one?
No? Bundle branches?
Nope.
What?
AFib. Atrial fibrillation, okay? Specific. Atrial fibrillation, okay? Atrial fibrillation is the most common dysrhythmia that you will have with heart disease, okay? So in saying that, what is the medication that we need to make sure that they are on? Anticoagulant, good, very good, because we have a risk of clots, okay? And then what other medication can we be on that's gonna help this AFib? A calcium channel blocker or a beta blocker, right? So think of mechanism of action there, right? Good, very good.
It's not.
For the arrhythmia or for the blood?
For the blood thinner.
There's Eliquis, Xarelto. Yeah, Eliquis and Xarelto. So some people are on dual antiplatelet therapy, meaning aspirin Plavix or aspirin Xarelto, aspirin Eliquis. They can't just use one, they need several and it could be because they also have a history of stroke as well, okay? Being an AFib increases your chance of having a stroke by 95%, all right, 95%. So just always think of that because the first place that clot's gonna go to is to the brain, okay? All right, and then of course, aneurysm. All right, what can we do? How do we control it? Take your medicine, right? Make sure you abide by that low sodium diet, right? That low fat diet, okay? And then their patients are telling me, well, what am I supposed to eat? Fruits, vegetables, drink plenty of water, right? Because when we're severely dehydrated, you're also at risk for clots, okay? Because what happens to the blood? It becomes thicker. Make sense? So even just hydration, okay? Let's see. It can be controlled, definitely not cured. Although the ones that are cured are the ones that usually come with other comorbidities. But if we can control those things, then usually your blood pressure starts coming down and I can start minimizing the amount of medications that I'm prescribing, okay? All right, very good. Okay, so lose weight, start moving around, avoid excessive alcohol use, okay? Because that dehydrates you. Stop smoking, manage your stress. Oh, that's so easy, right? Okay. Again, with the salt intake, eat for, what's a heart healthy meal? A heart healthy diet? Kind of already told them.
So
Low cholesterol, so low fat. What does that look like? Less cheese, less milk, less animal protein, right? Like pork and red meat, more chicken, more fish, leaner meats, right? Take off the skin and don't fry it. Does that make sense, right? And then of course, right. And then it's going to be a little bit more expensive. Extra virgin olive oil, avocado oil, coconut oil, vegetable canola, lots of fats, right? That's what I want you to educate your patient. Yes, you can say Mediterranean diet, but to me, I'm like, I don't even know what that is. It's another fad diet. I'm not going to do it. But if you tell them what is possible and realistic, they will abide. I promise you. Okay? All right. And then, of course, know which medications for sure you need to discuss with your physician as far as like, should I be on these 4 blood pressure medications? Yes, you have to take all 4 of those in order to control your blood pressure, right? I have a lot of patients that come to me that they're not necessarily able to afford all their meds, and then they stop taking their Plavix because it's well, not anymore, but it used to be very expensive. Okay? No, that's the one you have to be on. If you can't afford it, come to the clinic. We will figure out a medication assistance program to get you on it. We'll get you samples. We always make sure there's always a way to get your meds. You just have to ask. Okay? So just make sure that you know, you tell them which one is specific that they do need to be taking. They can buy all these vitamins. Vitamins are expensive. And I'm like, these vitamins aren't going to help you. You need this med, okay? You can actually take too many vitamins. Okay, let me see. Every time I have a patient that comes in, I always ask them, what's your blood pressure at home? Why am I asking that? Yeah, white coat syndrome is real. I never wear a white coat. 1, because they're too hot. But 2, because it usually makes them nervous, right? And then if they come into a specialist office when I'm at the kidney clinic, they're always like, oh, tell me, doc, how's my kidney function? Yeah, they're stressed out. So I'm not really going to go. I don't even know why we check their blood pressure, to tell you the truth. You know, because I always ask, what is it at home? You're in your environment. You're in a calm environment, right? You just woke up. I tell you to take it in the morning and the evening. I want to know how it is when you first wake up and you're relaxed versus when you just finish practically your whole day of working and moving around, right? Okay. All right. 10, these are perfect. Yeah. These are good to just know. So that way you go over these. Oh, this is what we go over with all cardiovascular patients on their floor, on our floors. Okay. They have to know these. Okay. Other medications that we're using are diuretics. We want some of that fluid to come off, right? Okay. I call diuretics the butler. Okay. Most of you might have learned that diuretics hurt the kidneys. Not necessarily. Diuretics help the kidneys, okay? It's the butler. So when things are in here and we're trapped, the butler's going to open the door for you so things can go out, okay? That's what Lasix is. That's what spironolactone is, all those things, okay? Now the dosages, if we're on too much for a long period of time, yes, eventually it can hurt the kidneys, but that is a bad doctor if they're not regulating those, okay? All right, beta blockers, how do those work? It decreases what? It decreases the cardiac workload, which increases the cardiac output. Okay. All right. Terminology, pretty much it relaxes the heart. It decreases the heart rate so that way it can pump, it can fill more with blood. And when it pumps, it gives you a nice forceful pump. Okay. Does that make sense? There's your decreased cardiac workload, increased cardiac output in a different phrase. Okay, so put it in ways that you guys can understand, because when you explain it to your patient, they need to know it that way. Okay, all right, and then of course calcium antagonists that relax the heart. Which ones are those specifically, Diana? Verapamil, very good. What else? All your prills. Yeah, your prills, very good. Okay, and your ACEs. I'm sorry, I was wrong. Verapamil is a calcium channel blocker. Your ACEs, your prills are your ACEs, right? What are your ARBs? Amlodipine, Narvast, that's the calcium channels. What are your ARBs? What do they end in? No? The OLs, right? The OLs are the beta blockers. Your prills are your ACE inhibitors. Your ARBs are your ARTANs. Your ARTANs, like losartan, right? Valsartan, okay? What, with the aces and arbs, what lab do I have to pay attention to that it doesn't go too high? Say it. Potassium. It's potassium, okay? So you need to make sure that you're checking your potassium on those. You're gonna see that on NCLEX, okay? Excuse me. All right, vasodilators, which ones are those? These are, what do they do? They dilate the vessel. So which one specific are you going to see on your NCLEX? Or on these, actually on this probably exam. A nitrate, specifically which one? Nitroglycerin. What's the dosage of nitroglycerin? That's the route, sublingual. What's the dosage? Not 10. You're gonna kill your patient, you give them 10.
0.5?
0.4 milligrams, okay? 1 tablet sublingual under the tongue every 5 minutes, up to how many times? Up to 3 times. What am I checking in between every single dosage? Blood pressure. If the blood pressure is less than what, do I stop taking it? 100. 100. If my SBP is less than 100, I can't give it. It's going to drop it even more. Okay? You're going to end up killing me. So even though you have blood pressure, you have chest pain still, in all this, hopefully we're getting to the hospital, right? If we're already in the hospital, you know, we need to make sure we're getting to where that might unclog me. Cath lab, so we can get a PCI, okay? So we can get that blood vessel opened. Very good. Good. All right. This one you don't need. We already got that one. Y'all know what that is. Another type of that. All right. Questions on blood pressure? Good. We good on time? Yeah. Okay. All right. So this is the nitty gritty. This is the stuff that I usually would teach the residents. I taught the interventionalists and then also all of the nurses at the hospital. Okay. So ACS, acute coronary syndrome. What is it?
Acute narrowing of the coronary artery.
Mm-hmm. That causes
Chest pain.
chest pain. Very good. Yep. Mm-hmm. Definitely. All right. And then it usually results in 2 types of heart attacks, right? We have a STEMI, which is complete blockage. Very good. And then the NSTEMI, incomplete, right? But it can lead to the full one, right? The big bad one. Very good. Very good. Okay. So we have also unstable angina. Unstable angina just means that I'm having chest pain while at rest, okay? While at rest, okay? Very good. So our biggest thing is that we want to make sure that we rapidly diagnose these patients. So as soon as they come into the ER, we have 10 minutes to get an EKG, right? Because that is your factor. That is the diagnostic of choice in order to confirm your suspicion of a chest painer, all right? Okay, so we'll see the elevation in the ST segment. If I see that, now I'm calling my code STEMI, right? I'm calling a cardiac alert. So once the cardiac alert is called, I have about 10 minutes. I'm sorry, I have about 30 minutes to get all of my medications done, okay? What medications are we gonna give if I'm having a heart attack?
Nitro, oxygen, morphine, and morphine, oxygen, nitro, and
What's the A? Not atropine. Because what am I having when I have a heart attack? What's aspirin? Very good. Aspirin. Say it loud and proud, girl, because I can't hear you. Okay, so aspirin. How much aspirin?
81.
Not 81. That's a baby aspirin. I got a big ass clot. Sorry. I got a big clot. That happens a lot. Sorry. 324. Okay, 324 milligrams of aspirin. All right. So again, I don't need the Chihuahua when I need the big dog. All right. Okay. All right. And then we have, different comorbidities that might be causing this. So they're listed on the bottom. High blood pressure, high cholesterol, diabetes, right? Okay. They all lead to this. All right. So normally this is what's happening. The narrowing of the carotid artery. Here's some nice pretty pictures of that. But pretty much it's all that fatty deposit that's happening. And then to the point where it narrows, Or I have some of that plaque that breaks off and it literally lodges itself in there where it cuts off my circulation, okay? Now, when the coronary arteries are blocked, that impedes that circulation to the heart muscle, and heart muscle dies. Heart muscle does not regenerate, unfortunately, okay? All right, that's where heart failure sets in. Okay, so here are some risk factors. Like I said, we've been talking about these, specifically also cigarette smoking, and then of course the things like family genes and all that kind of stuff. Okay, and then of course we've just recently, well, not recently, I guess it's been a few years, but COVID-19 has also caused lots of coagulopathy issues, meaning that we have lots of extra blood clots after COVID-19, okay? When we were doing studies on the patients, or like autopsies, we found them full of clots after they've died from COVID-19. Okay, you guys can watch this because it's about 10 minutes, but it pretty much kind of shows you the cellular part along with the symptomology of how a patient feels during a heart attack, okay? All right, so we're gonna have chest pain, shortness of breath. We'll have fatigue probably for a few weeks, right? Normally you'll see these abuelitas, these little grandmothers that they're like, yeah, I've been having chest pain for like about 4 days, mostly in my shoulders and my back. And I've had a student where she even took like her grandmother to the hospital. Ma'am, you've been having a heart attack already for like, when did this start? About 4 days. Yeah, I've heard about then, since then. She was having an NSTEMI, right? An incomplete blockage. And then she's like, yeah, I mean, I thought it was just my back. That's going to be me like in 30 years, right? Hopefully not. If so, then you guys are treating me. So nurses make the worst patients, just FYI. Okay. And then of course, angina. What is angina? Chest pain, but don't forget that it's temporary, okay? So sometimes, like if I have chest pain, I'll be like, maybe it's heartburn, okay? So when I have a patient in the hospital that's on a cardiac floor, what 2 medications I need to make sure that they're on that are not cardiac meds?
Omeprazole,
Which is a,
acid reducer.
so acid reducer, so a PPI, right? Proton pump inhibitor. So it doesn't have to be actually pantoprazole, but a proton pump inhibitor, because there's a lot out there, right? Famotidine, pantoprazole, omeprazole. And then what other medication do I want? Esomeprazole is another. But what other medication do I want that is not cardiac related? Not a cardiac med. Not antibiotic. No. No. A stool softener. We're going to go over that here in a minute, okay? All right, okay. So with the PPI, the reason why I want that is because acid reflux mimics chest pain, okay? So I need to make sure that it's not acid reflux. So every patient that comes in with the heart problem, they get a PPI. We're handing out PPI for you, okay? Because I want to make sure that if you have chest pain, it actually is cardiac-wise. It's cardiac related. It's not necessarily GI, okay? All right. Now, some people will have that gas-like pain. They'll get restless, right? Nausea, vomiting. Now that is all because we stimulate which nerve?
Vagus.
The vagus nerve, okay? Hence why we need to keep them nice and clear with stool softeners, okay? Because the moment that I strain and I hug that toilet because I can't go poo, right? I'm going to stimulate that vagus nerve. What happens to your heart rate whenever that happens, when you stimulate it? It goes down. It decreases, right? You get that tunnel vision. Don't tell me you haven't felt it. That tunnel vision. And then all of a sudden it's like, boom, boom, the vasovagal syncope. But hopefully you and I, we all have good ejection fractions. We have good heart muscles, right? But when it comes to people with heart failure or already problems with their heart, they might not have a very strong heart muscle. And guess what? Bad things happen in bathrooms on a heart floor.
Like Elvis.
I love you. You're my friend over here. I'm an Elvis fan. Okay.
He's doing?
That was he was doing. He was chronically constipated because of all the opioids he used. Okay. He was also diabetic and in heart failure. So when he was pooping, He vagaled to the point where he ended up collapsing and died in the toilet. Okay, so now you guys know why we need stool softeners. Got it? Okay, all right, very good. Okay, so again, early perfusion is what we want, right? Time is muscle. We need to make sure that we try to restore that blood flow to those coronary arteries. So in the hospital setting, we give all those meds, including Plavix. Now you'll see that they give Brilinta. Brilinta is another anticoagulant other than Plavix that we can give. However, it is very expensive, okay? So, and then we also do thrombolytics. What's a thrombolytic? Right, so a clot buster, right? Okay, so it's a clot buster. So we have 30 minutes until from that patient hit the door to get to a clot buster. We'll give a thrombolytic. We give TNCase here in Corpus Christi at all of our hospitals for stroke and also for heart attacks, okay? That is your clot buster. If it busts that clot open, we get reperfused, right? The clock stops. But if it doesn't happen and the patient still has chest pain, then we're going to the cath lab. We need to go and fish that thing out, okay? So from the time that the patient is seen by EMS, right, that we get that EKG, and then to the point of PCI, we have 90 minutes to make sure that that muscle stays alive, okay? All right, that's what the American College of Cardiology tells us, okay? All right, so this is a little grid that I like. If you have EKG changes, yes, it's a STEMI. If no, we do cardiac biomarkers. And if they are raised, but there's no EKG changes, they have unstable angina, right? If we do have the EKG changes with also cardiac biomarkers that are elevated, it can be NSTEMI or STEMI, okay, depending on what the EKG looks like, okay? All right. All right, that's practically the same thing. Okay, so what are your cardiac biomarkers? What lab tests? BNP is more for heart failure. So we will do that one after. Troponin I, right? However, if you're in chronic kidney disease, your troponin I's will automatically be elevated. So you need that. That's why I'm saying you need that EKG, right? What else? What other labs? Creatinin's kidney. Say it again. Yeah, CK. So creatine kinase. Yes, CK for sure. Yes, CK for sure. And then what else? Myoglobin. What else? Starts in lipid, ends in profile. Lipid profile. I want to check your cholesterol, right? I want to check your cholesterol. Now, not every patient that comes in with a STEMI has high cholesterol, just FYI, okay? I had a patient I sent in and I'm like, what do you mean you had a heart attack? You don't have, I'm like, wait a second, you don't have anything. How did you have this? He got severely dehydrated working outside and had a coronary artery that got occluded. Yeah, I know. Horrible, horrible. I was like, oh my goodness. Okay, but this is again why we need to make sure we're checking for PQRST, okay? All right, and you see the EKG changes. So STEMI looks like a tombstone. Uh-oh, graveyard, we don't want that, right? But then the NSTEMI, you'll have a decreased, right? Kind of a dip in your ST segment. So two huge differences, okay? All right, very, the dip, look at this one on the top, that top right one. You see the dip where it comes under the actual like baseline, and then the STEMI is very high. Okay. Yes, you're welcome. All right. So this slide tells you all about your troponins, your normals, right? We trend them. So troponin would not. Yes, it's the lab of choice, right? But we don't go off of that in order to say, hey, your patient's having a heart attack, right? Okay, because this takes a little while for it to rise. It might take up to about 4 to 6 hours for you to start having a high level. Now, if your patient's already been having chest pain for a few days, then yeah, they're gonna present to you high, right? Okay, but if it's something that like, oh, it just started like 5 minutes ago and I walked in here or whatever, right, 10 minutes ago, then it may not be high yet. We draw the lab, but it may not be high until we get the result back a little bit later, okay? That EKG is what's gonna tell you if you have one or not, okay? It's gonna make you act. And then of course, we're looking at all the good, your cholesterol. Yes, ma'am.
Are there any other reasons why troponin like could be high?
Kidney problems.
Oh, okay.
End stage renal disease. All right, and then so your cholesterol levels, right? You want your total cholesterol. There's 4 levels in the lipid profile. Total cholesterol needs to be less than 200, right? Okay, triglyceride level can be high, like just because you ate, something really fatty too recently. Okay, so but you want that one less than 150. Your HDL is your good or bad? Your good cholesterol, right? Good fats, which is good. I always tell patients, it's like your big sister. If the big sister's nice and high, then she can tame the other ones, right? That's why like the bee on the Cheerios commercial says, Cheerios can lower your cholesterol because it's good cholesterol. It's oats. Oats are good cholesterol, okay? And then your LDL is your bad cholesterol. You want it less than 100, okay? If your triglycerides are super, super high, you can't even calculate an LDL. That's the patient that I'm like, you got to do something right now, and I'm putting you on all these meds, okay? What medication do I put on a patient with a high cholesterol? A statin, yeah, definitely a statin. Now, when your patient comes in with a clot already, right? Because a statin is to prevent, hopefully, all of that buildup, right? The clots. But when they already come in with the clot, we want to put them on a high intensity statin so we don't get another incidence of buildup, right? So 40 milligrams, 80 milligrams, not just the 10, the 5, things like that, okay? So you want to put a statin. Now, most of my patients that have had heart attacks are like, I don't like a statin. I don't want to take it. Why? What's the major side effect of that medication?
Doesn't have like, doesn't have sexual side effects.
Nope. That's your beta blocker.
Alzheimer's.
Nope.
Wait,
No. You get lots of muscle aching. It's painful for the muscle, okay? So a lot of them are very non-compliant because they're like, no, my muscles hurt so much. I'm always hurting on that medication. It's that, or you have another heart attack. Choose your poison, okay? So most of them will just still take it. Most males will not take their beta blockers because it lowers their blood pressure, not lowers their blood pressure, I'm sorry. It lowers their heart rate so much, right? And it sustains their blood pressure nice and steady that they have a decreased libido. They end up with erectile dysfunction. So a lot of them say, I'm not gonna take it. Okay, get yourself 1 girlfriend instead of 2 and then explain it, okay? All right, okay? I'll give you the little blue pill for those instances, but on the other days, you got to take this one. All right. Okay. All right. So we're going to do an echo after the event because we want to see what kind of heart function we're left with, right? So we're looking for an ejection fraction. That's how much left ventricle muscle we have left. If it's 50 or more, we're okay. That's normal. Okay. And you'll see some that have like 65, which is good. But if we've had some type of cardiac event, you're going to lose some of that. This can go up in a few months after the event. So we'll do another echo in about 3 months after a heart attack, just to see if it's changed, okay? What else in the echo do we look at as well? Because we're thinking calcification, we're thinking cholesterol. Where can it gang up on in the heart? Other than that, in the valves. Yeah, in the valves, okay? So that'll tell us if those doors are opening and closing correctly, okay? All right, very good. All right, we're gonna do exercise stress tests. We're gonna do, like I said, the stress echocardiograms. When there's different types of stress tests, there's now that the patient can walk on a treadmill, right? There's some that we can give you medication if you have bad knees or shin splints, whatever. We can give you medication through an IV to stress your heart out and pick up that heart rate to see if we can mimic the cardiac event, right? And then we can put you on a bicycle now, okay, to try to work your heart out and see if it's just that it's not conditioned or do we have issues to where we're at risk for a cardiac event like a heart attack, okay? All right. We talked about thrombolytics, the clot busters, okay? The nitroglycerin, antiplatelet drugs like Plavix and Brilinta, okay? Beta blockers, your ACEs and ARBs, and your statins. And then, of course, angioplasty and stenting. That's when the patient goes to the cath lab, okay? If for some reason we can't get that clot out in the cath lab, patient goes for open heart, okay? Oops. All right, so this is what the coronary angiography looks like, okay? So there's the plaqued vessel. Once we get in there, we can open up a stent to push all that plaque to the side. It doesn't get rid of it, but it pushes it to the side and opens up the vein so we can get reperfusion, okay? And then on the left side, you can kind of see where it's closed off. That's where it's pinched, right? It's occluded. So once we put this stent in, it'll open up, okay? All right. Now we do have also balloon angioplasties where it's no stent involved. We don't leave a stent in there. But what we do is we'll put the balloon in and we push everything to the side just to kind of open up the highway. All right, does that make sense? So there's a couple of different interventions we can do. A PCI, like I said, is the stent. We don't necessarily go in and fish anything out or anything like that. Like nothing comes out. It's that we go put in something to open up that vessel.
That not used for pressure.
Yes, so you still have to, yeah, you'll have to put on a anticoagulant so that the stent doesn't restenose, so it doesn't get clogged all over again. Because what happens when we put something in your body that you weren't born with? We try to reject it, right? We try to reject it. So part of that is if it sees anything in there, it's going to try to clot and send different types of cells. So we need to put anticoagulants on the treatment plan so that way our device doesn't fail.
So there'll be
Not for the rest of the life. Up until we know for sure that they can change all of these lifestyle things first too. Yeah. So that's a good question because lots of people say, I don't want to be that on for the rest of my life. Well, the sooner you make all these changes, the sooner we can reevaluate taking that medication off, right? Okay. So meaning stop smoking, eat better, move around, monitor your cholesterol, make sure you follow up with your physician and all of your specialists. You need to make sure you regulate your blood pressure, right? Take all your medications, manage your stress, and you need to stop drinking so much, okay? Maybe not, one less taco a week. Let's start off, right? No energy drinks, okay? I told you guys I'm a heart nurse. All right. Okay, so these are some of the rules we have to abide by in the hospital, all right? So pay attention to the door to balloon time, 90 minutes, okay? Now, that means that from the time that the patient gets there to the time that we open up that vessel is 90 minutes. So that includes prepping the patient, getting the patient through the ER, the time that the EMS had to work with them and everything, 90 minutes. Now, if
Let me ask,
Mhm.
do you count normally the minutes or the time the patient is taken from home? Or
Yes.
just to count only the time the patient is waiting for hospital center?
From when they are from home. So good question, because the American College of Cardiology says that we have, if say our patients live in Beeville, if they live in Alice, if they live in Kingsville, if they're outside of the city limit, they even let us use south because it's 45 minutes all the way to the shoreline, okay? If we're like on the south side. They give us 120 minutes to kind of help with that travel time, okay? Lots of cardiologists are always telling the patients, do not even call for a helicopter. Helicopters take longer to take off and to land than it is to get into an ambulance and then drive as fast as they can, okay? That's why we say stop in Alice, stop in Kingsville, stop at South, stop at Beeville, so we can get those thrombolytics and save you some time, right? If those thrombolytics work and it busts that clot open and we perfuse, the clock stops, okay? But we have 30 minutes to get there, right? Or else it doesn't count, right? For the metrics. But for the patient, stop there anyway. Don't bypass that facility, right? Now, if you still have chest pain, you at least were able to get the aspirin, the Mona. You got all the Mona, right? And the Plavix. And then now bring them to Shoreline so we can go to the cath lab. Because those places don't have cath labs, right? Okay. So you see kind of the progression of that. But metrics say they give us extra time, 120 minutes. But it's typically 90. But that includes the fire department, right? The
Is there
EMS.
Physiology behind the 90 minutes?
Is it
Like the physiology behind the 90 minutes?
time is muscle? Because they've done studies to where it says if you don't get intervention by 90 minutes, your heart will not survive. So we have, yeah, yeah. And I think that they're thinking of possibly giving us shorter time now too, because there's more studies coming out that we need more rapid intervention. All right, so what is the difference between a STEMI and an NSTEMI, right? STEMI involves the ECG changes, the EKG changes. NSTEMI, not the EKG changes, but we do have the elevated biomarkers, okay? And then you'll go back to this little grid there. All right, what's the normal left ventricular ejection fraction? 50. Very good. All right. Do you have any questions? Did y'all learn anything? Yeah? Okay. If not, you can lie to me. Hopefully you remember. So I hit the key points. All right. Diagnostic of choice, lab of choice. What is our goal? What's the time? What medications? Okay. And then once everything's done, you do your BNP and you also do your echo to see what's left, right? Are we in heart failure after this heart attack or are we not? Okay. All right.
What are biomarkers?
Your troponin, your CK, your lipid profile, all of those. Those are your biomarkers. Oh, well, NCLEX will tell you troponin. So troponin, yeah, yeah. But once you get to the hospital, like actually practicing, once you're done with NCLEX and you've passed it, okay, because we're all going to pass, then you can learn the extra stuff. But this is something that I would use to teach residents, interns, nurses. I mean, we're done with NCLEX, but I just told you guys today the stuff that would be on there. Okay. So nitro is one, know the dosage, route, complications, right? What is it for? And then how do we distribute it? Because you will need to know that for sure. Okay. All right. Any other questions on ACS? No? 0.4. And then so let me tell you, this came out in a movie too, and you guys might know this, but if I have a patient that is having chest pain, okay, they came to the hospital because they were having chest pain, they took the little blue pill because they started having chest pain during sexual activity. Do y'all know what little blue pill I'm talking about? Okay, so that's sildenafil or tadalafil, okay? All right. What can I not give them? Nitro, because it's going to decrease their blood pressure even more. All right, okay, makes sense? So whenever a patient comes in, and we've had this happen, we ask them, what were you doing? This is the important part of that history part, okay? What were you doing when all this started happening? And then I always usually tell them, because I work DR, and I would tell them, okay, so you were doing your lawn, but you're not dirty, okay? You don't have pieces of grass in your hair and your ears, right? Because usually that's where it goes. I said, so you seem pretty, okay. Are you sure we weren't having any type of sexual activity, yada, yada? Because I'm about to give you a med that if you were having these symptoms during sex, then I can't give it to you because I'm going to kill you. And they were like, oh, yeah, well, that's what I was doing. That was what I was doing, right? Okay. All right. Any other questions? No? Okay. For those of you that want to do peds, anyone want to do peds? Okay. You guys are more than likely, if you go to CV, if you do CV for pediatrics, you're going to give lots of Viagra to these kids. Pulmonary hypertension. So Viagra was first made in order to treat pulmonary hypertension. When they saw the effects of it, Of course, they started making money for other things, okay? But that's what you use it for pulmonary hypertension, okay? Not necessarily just for ED, okay? All right. Any other questions? No? All right, let's go through dysrhythmias right quick. Okay, so the stuff that you're gonna need to, oh, they need a quick break? Okay, have at it. Sorry, because I can keep going. Oh.
And we still have to do the fundamentals. Yeah, and max.
And this won't take me that long. I'm gonna go through it real fast. Do I pause anything? You see?
Yeah, pause the recording.
More. Okay, you guys. So here we go. Okay, so you guys know the blood flow of the heart? Yep. Okay, good. All right, so we have the right atrium, the left atrium, the right ventricle, and the left ventricle. So normally here, this is the electrical conduction of the heart, okay? So you start off at the SA node, right? That's pretty much like your powerhouse. That's where all of the electrical currencies are gonna start, okay? Then they go into the AV node. AV node is what I usually call the gatekeeper, all right? So let's put it into kind of a scenario, all right? Me and my girlfriends, although this was me before, not anymore, I don't do this anymore, but we are gonna go out dancing. We're gonna go to the club, whatever, right? We're gonna go to a party. So they're at the SA node, we're at the apartment, right? We're getting ready. We're getting all gussied up, right? We're making sure that everyone takes a poo so we can fit into our dress. Make sure that there's no bulging anywhere, putting the Spanx on, everything, right? Okay, we're getting prepared. The AV node, we're going to the club. The AV node is the gatekeeper, right? It's the bouncer. He's going to tell us if we're dressed to impress and we're able to get in or not. Okay? All right. Bundle of his, you're going down the hallway to the actual dancing area. Okay? And then left and right bundle, we're going to separate. One of my friends are going to go to the bar. I'm going to go probably sit down, and the other ones are going to the dance floor. Okay? And then the Purkinje fibers, that's where all the action happens. That's the dance floor. Make sense? Okay? So when we have electrical conduction defects, people just start doing different things, right? Either we're not dressed to impress and we don't get in, or the bouncer somehow is sick, they're overwhelmed, they're distracted, and too many people get in at once that shouldn't be sneaking in. So things like that. But if you keep that kind of concept, you'll kind of know these are the routes of how electricity travels throughout the heart for us to be able to get a good contraction, okay? All right. Now, when we do our 5-lead EKG, our 5-lead placement for telemetry, y'all know the placement. Y'all have your acronyms that you know. Yeah, I'm more of a foodie. I think of like a hamburger, okay? Or, as long as you know your anatomy, the heart's on this side, typically. Your gallbladder's on the right side. The liver goes all the way to the middle of your belly, okay? And then, of course, salt and pepper, okay? All right, very good. Whenever we do a 12-lead EKG, you do the second picture over here with V1, V2. A monkey can't get it wrong, guys, because it's all numbered, okay? So the big thing is that V1 goes on one side of the sternum, V2 on the second. It's usually on the fourth intercostal space, okay? Now, it's very difficult, especially here in South Texas, to feel people's ribs because they got lots of extra fluff, okay? So you do your best. You do your best, all right? And then, of course, what's not shown on there is you have the 2 arm leads and then the 2 leg leads, okay? All right. Okie dokie. So what happens during the P wave? Activation of the atria, right? So the atria starts to contract, right? What happens in the QRS? The ventricles contract. What happens in the T wave? The ventricles relax. You gotta know that for NCLEX. Okay, it's gonna come out. What is the QRS? What does it signify? Ventricular contraction, right? What is the P wave? Atrial contraction. Got it? T wave, ventricular repolarization. It's the resting period. It's pre-filling again to get ready for the next beat. Okay? All right, very good. Okie dokie. So, and this stuff pretty much tells you how we measure the EKG. Okay? So, big thing here is knowing these two numbers. Each little box is 0.04 seconds. When we have 5 of those, it makes a big box. Do the math. 0.04 times 5 is 0.2. Okay, so even if you remember 1, just know that 5 little boxes makes a big box. Okay, I'll show you guys here what that means. You see where the top part of this illustration, it has 5 boxes around the bottom, makes a bigger box. Okay, all right. This kind of just breaks it down for you. Now, when I have what's called a PR interval, this is what I'm going to look for in order to say if I have a first degree block or not, okay? A QRS complex is going to tell me if I have a bundle branch block. If there's something delayed somewhere in those parts of the contraction, I need to measure, and those numbers are going to tell me if it's present or not, okay? QT interval, this is why that patient that was 30-something that I sent to the hospital, when her EKG showed me she had a QT interval prolongation, I freaked. I said, oh, you got to go to the hospital. That could be fatal from like this second to the next, okay? We should not be delayed in that. And then, of course, she was having all these heart failure symptoms. Okay, so big thing here, the 6-second method or 6-step method to doing your EKG interpretation is that you want to look to see if there's P waves, okay? If there is no P wave, that's not normal, okay? But if there's a P wave, then I have that atrial contraction. So you're looking for those, because if you don't have them, you're going to go into what's called like a fib, a flutter. So you always want to ask yourself and look for those P waves, okay? You're going to measure your PR interval. This is going to tell you if you have a block present or not. Your QRS, we want to make sure that there's one there, because if there isn't, what's going on with my patient? The ventricle is not contracting. My patient's done, okay? Identify the rhythm. We're going to do some practice here. And then, of course, the heart rate, okay? Now, with the heart rate, if it's 0 to 60, normal, okay? If it's over 60, I tricked y'all. I tricked y'all. You're not paying attention. After this break, y'all thought we were done. Brady, we're Brady, right? 0 to 60, we're slow. We're bradycardic, okay? 60 to 100, we're okay. We're normal. 100 to 150, tachy. 150 and over, supratachy, right? Supraventricular tachycardia. There you go. Hey, so you got it. You got it. All right. Okay. So in a normal strip, you're going to have an upright P wave, correct? Okay. All right. Very good. Now, what we do to measure the PR interval is we're going to count the amount of small boxes from the beginning of the P all the way to the beginning of the T wave, or the Q, I'm sorry, Q wave, right? The Q wave, okay? So y'all see that little picture there? I should make that one bigger. All right. The QRS is from the beginning of the Q to include the R all the way to the end of the S, okay? All right. And then we want to know if the rhythm is regular or irregular, okay? So normally what I tell students too, because it's kind of difficult for me to kind of see that, I get the white piece of paper we always give you guys for exams, okay? I march it. I put it up to the monitor. I put a line there and a line there, and then I march it from the next one to the next one. If they match, it's regular. If it doesn't match, there's irregularity in there, right? So something's off. Something's not necessarily correlating step to step. So we did it in the monitoring room with calipers. So it's this little kind of little, I don't know, like little thing like that, and it has 2 little needles, and we would just mark them. We'd make them march. Okay, do it with your paper, same thing. Okay. All right. If it's like I said, if it's marching, it's regular. Now with this one, we're going to look at the tick marks, okay? The tick marks meaning those 3 lines at the top, okay? The black ones, correct. So from tick mark to tick mark, right? From the first one to the second one, that space in between is 3 seconds, okay? From this tick mark to the last one is another 3 seconds. So if you have all that stretch, that's a 6-second strip. If you have 6 seconds, enough on a strip, you're able to pretty much calculate the heart rate with that, okay? And you're going to pretty much count all of the QRSs that are within that period. So what is your rate here?
7.
What do you think? 7? We have a 70. Anybody else?
68.
It's by tens. So you're about a 70. Yeah, 70 would be correct, okay? So 70 would be correct. If you would say 60, I'd still count it anyway because it's by tens, right? So each QRS times 10 gives you a heart rate of 70. But you see how this last one is right there on that tick mark? But then look at that first one. You're kind of away from that tick mark. So you can assume that if you were to move it a little bit, that it would be exactly about 70, okay? All right? So very good, very good. Those can be a little tricky, but like I said, on an exam, usually they don't make it that tricky, okay? All right, so this one says 60, right? Because it didn't count the one that was outside the tick mark. But again, on one of our exams, if it was that, like that, we would give you either or, but technically it would be the 60, okay? All right, very good. All right, this method involves a lot of math, lots of math. And it's pretty much divide 300 by the number of boxes that are in there. Well, again, too much math. Now, the reason why we have this is in case that, because back then we had where we would print out strips, okay? And now we have electronics that just print out an actual 6 seconds all the time. Like you can, the teletext can actually give you a 6-second strip all the time. Sometimes we wouldn't catch enough. We didn't have enough of that, okay? So you would use this method, but it's kind of phasing out. So method of 10 is good, all right? All right, very good. Now let's interpret some stuff. Now we said sinus rhythms, those are usually normal rhythms, okay? And then that means that depending on the rate, we either have sinus brady or we have sinus tachy, okay? All right, but normal means that I have a P wave, I have a QRS, and I have a T wave, okay? That's what normal means. All righty. So sinus is a heart rate of 60 to 100, right? And this says follows normal conduction pattern. Again, it has a P, a QRS, and a T. So always look to make sure that everything is there for you, okay? Sinus bradycardia, you see the tick marks? This is the heart rate of what? 40, okay? So you have your P, you have your QRS, and you have your T. The heart rate is low, okay? And then of course it's regular, right? You're always looking for regular, irregular, making sure all your components are there, and then you look at your heart rate, okay? All right. These are some of the things that patients might be feeling when they're sinus brady, right? I don't have enough perfusion. I don't have enough blood pumping, okay? So I'm going to be hypotensive, right? My blood pressure is going to be low. I'm going to be pale. I'm going to have some cool skin. Why do I have pale, cool skin? Because I'm not getting enough perfusion. The circulation isn't enough to get to my fingers and toes, right? Okay. Gonna be a little bit weak, not gonna have enough energy. I may have a little bit of chest pain. Again, my heart now is not getting enough oxygen, my heart muscle, right? Might be dizzy, my brain's not getting enough oxygen, okay? And then confusion or disorientation, same thing. And then shortness of breath. I'm trying to compensate and trying to get enough oxygen to fingers and toes, but yet my heart's not delivering it as fast as I would like it to. Make sense? Okay? All right. You got to know why, we're in the why right now. And you need to know exactly what you're going to anticipate and seeing in your patient, because then you can work backwards. When your patient presents to you with all these things, then you can start figuring out what could be wrong with this patient, right? What do I need to check to make sure that it's within normal limits? All right, for sinus brady, we want to give atropine. Now, the big thing with atropine is that yes, it works, but it's very short-lived. It doesn't last very long, okay? So here we would probably have to go into more of like a vasopressor. that is a chronotrope, meaning that it deals with numbers. Do you know which one specific? Which one specific? Which med? Because no one's going to ask you which one do I want, alpha or beta. Nope. They want to know which specific chronotrope am I going to give in a drip?
Probably more rapid.
Nope.
Butamine?
Nope.
For increased heart rate?
Mm-hmm. Dopamine. Dopamine is the chronotrope, okay? Dopamine is the chronotrope. Very good. And then eventually that patient can't go home on dopamine, but this is going to be in the meantime that I need to give you a pacemaker. I need to give you a little box in your chest that's going to beat for you in order to get you to a good 60 to 70 beats per minute so that you perfuse adequately. Okay? All right. And then we're going to stop offending drugs. What offending drugs do you think we need to say, hey, stop taking that because this is what's causing it? Beta blockers specifically, right? Okay, very good, because those decrease your heart rate. All right, sinus tachycardia. We have our P, we have our QRS, we have our T, right? It's in a regular rhythm, okay? It marches out. It's just that it's high. The heart rate is high. It's over 100, okay? Looks similar, huh? The manifestations, right? So the patient could present this way, but we need to use all of our diagnostics, all of our resources in order to figure out what specifically is happening to this patient.
How come you have hypertension on both of them? Wouldn't your body try and compensate with rate?
Not with the heart patient, right? So if I have high, think of how it's working. If I have a high heart rate, I don't have enough time to fill with blood, right? So it's barely filling because it's going so fast. So you're going to have a low blood pressure. Every one of those beats is pretty much like it hardly has anything. So you'll have that low blood pressure. Does that make sense? Because I may have a full thing of, I may have a full ventricle of blood pumping, but I don't have enough pumps. So you'll still have the low blood pressure. Y'all see that? Okay. All right. Some of the treatments here is obviously we need to treat the underlying cause. Sometimes it's pain, right? And we can use beta blockers to help with that heart rate to come down, or we can do vagal maneuvers, right? What are some vagal maneuvers? What am I going to tell the patient to do? What does that mean? Try to fart. Make it simple. Everyone knows how to do that, okay? Except for kids. Oh, man, some of them do, right? But you want to tell them, you know what? Let's bear down. What do you mean? Pretend like you need to poop. No, I don't want to poop. Most of them won't do that. Just pass gas. Let's fart. Let's fart real quick, right? How about we cough really hard? Take a deep breath and cough. That does your vagal, it's a vagal response, okay? So again, be a little bit more appropriate with your verbiage when you're treating patients. Your NCLEX is going to go all the way down to how you're educating your patient. You're looking for certain things you've learned, but how do you interpret that into a patient that has no idea what the training that you've received, okay? All right? I'm a stickler with that with my students for sure. I'm like, what does that mean? I don't know what that means. Okay, I dumb myself all the way down. Okay, all right. Now, when I don't have those normal sinus rhythms, now I'm going into atrial rhythms, meaning that something's up at the house, something in the party. Maybe we started early. Maybe one of us doesn't want to go. Something's up, right? We're not all on the same page. All right, these are a few of your atrial rhythms: atrial flutter, atrial fib, supraventricular tachycardia, and of course PACs, meaning that I have early atrial contractions. All right, atrial flutter. This is where you have what we call saw teeth, right? So it looks like a sawtooth type of thing. You turn it up, you turn it down, it's very striky. Some of them are, or I would say most of them are all regular. You see how it's like a 4-to-1 ratio, 4-to-1 ratio, 4-to-1 ratio? 4-to-1 meaning 4 of the P waves to 1 QRS, 4 P waves to a QRS, right? Okay, you don't even know which one's the T, which one's the, if it looks like a P, they all look the same, right? So that's how you can tell if it's an atrial flutter. Not 100% of the time will it be regular, okay? But this one is. Not 100% of the time will these be regular. You can have a 2-1, 3-1, 4-1, you know, things like that. But in about 90% of the instance, it will be regular, okay?
Do you mind to go to AFib? Something like this.
That's the A flutter. We haven't done AFib yet. Yeah, it's coming, I promise. Okay. All right, so these are the manifestations to the patient. This is how they're going to feel. You're going to feel that thready pulse. And then, of course, the decreased urine output. Okay, decreased urine output here. All right, so some of the treatments that we can do here, you're going to look at those, like amiodarone is one that you're going to use religiously in the hospital. Okay, this is an antidysrhythmic. It's going to try to pretty much convert your patient back into a normal rhythm. Okay, we can also do cardioversion, meaning that I take you to the cath lab and I restart your heart, and hopefully it restarts in a normal sinus rhythm. Okay. So, and then of course we can do an ablation, meaning that the cardiologist, the electrophysiologist goes in and they pretty much look for that one part in the right atrium that keeps firing up. Something is getting past that SA node, or someone has left the apartment and they're out doing something else, right? And they're firing an extra current. And the cardiologist has to go and look for it and cauterize it, burn it, so it can stop, so it can settle down. Okay, so and that is an ablation. And then of course we need to put this patient on blood thinners, because what happens whenever we're not sure if it stays in a normal rhythm and it goes into an irregular rhythm, the blood can pool. When blood pools, it clots. Okay, so we have to put them on blood thinners. For the blood thinners? For the amiodarone is the most popular. Amiodarone is the most popular. All right, atrial fibrillation. So this is where we don't have those saw teeth. All you have is literally that atria is seizing, right? It's literally quivering. There's no pretty much structure to how it's pumping. It's literally just seizing, okay? And then seizing, pump, seizing, pump, but there's no necessary like cadence, right? There's no rhythm to it. So it's irregular, right? You don't know when that QRS is going to happen. So definitely for this patient, you have to have them on an anticoagulant, all right? Because they will clot. Now this rate can be slow or it can be fast, right? We don't want either or because we don't get enough perfusion either which way, okay? All right, paroxysmal or persistent. Paroxysmal means that it happens here and there, right? I feel it when I'm really stressed, but then it goes away. I feel it whenever I have, an upper respiratory infection, and then it goes away, right? I feel it during, football season, and then after Super Bowl, it goes away, okay? Persistent, I have it regardless of what I'm doing, okay? All right. Regardless if you're on paroxysmal or persistent, you're always on a blood thinner because we don't know when it can happen. So you have to be prepared all the time, okay? Again, it's the most common dysrhythmia. Say that again. Because when the atria doesn't have a rhythm, right? The blood doesn't keep going in a rhythm. It can pool, it stays stagnant. Have you ever bled onto the floor? All of a sudden it's clotted. That's what happens to blood. So if it stays in one spot and it doesn't move, it's going to start producing clots.
So meaning the artery is not pumping, but
Correct. Correct. Right. It's not in a, it doesn't keep the blood moving in a rhythm, right? It's always flowing, kind of like a river is always flowing. That's why the water's clear, right? But the moment it sits, like in our ocean, it sits, it's all dirty. Does that make sense? There's sediment in there, okay? All right, so let's see what else here. Same thing, manifestations look the same, right? So we need to get this patient on tele to figure out what's happening. Is it an electrical conduction problem, okay? All right, so in AFib, like I said, we use a pharmacologic agent, okay? Amiodarone, we can use cardizem as well, okay? Calcium channel blocker. We make sure that we prevent stroke and give a blood thinner. And then again, we need to convert this patient, right? We'll try the cardioversion, we'll try medications in order to convert them. Sometimes it doesn't work. Then we just keep them on a consistent calcium channel blocker so we can do some rate control, okay? Some patients will get a pacemaker. All right. Premature atrial contraction is this what it says. It's an early beat, right? But it has everything associated to it. It has a P, it has a QRS, it has a T. It's just early. It makes your rhythm irregular. That's all that says. Okay, so it's just an early full beat. Some of the causes of this: stress, fatigue, right? Caffeine. So those of you that have Red Bulls and all that, and all of a sudden, like it's the end of the semester, you're taking finals, you're super stressed, you're like literally not sleeping, you're eating like crap, right? You're dehydrated because you're drinking more soda than water, right? All of that kind of comes at the end, and then push in that monster. And guess what? Oh, man, my heart's fluttering. You're having PACs, you're doing it to yourself. Professor Hernandez told you to throw that stuff away. Okay. All right. So just think of those things. Okay. All right. Your heart skips a beat. You're having palpitations. And then what we're doing is we're making sure that we monitor for more serious stuff, right? Like now you say you come, let's say you go to the school clinic or whatever. That nurse hopefully will put you on a monitor. We'll check your pulses, make sure that it's regular, irregular, right? Probably give you a baby aspirin until you go to the hospital. Okay. Or how about you go, one, drink plenty of water, stop drinking the Red Bulls, right? Go get some rest, go take a nap, and then hopefully you're fine in a few hours. Okay. Because at 19, hopefully you don't have any heart problems. Okay. All right. Questions so far? You with me? Okay. Supraventricular tachycardia, we said the heart rate was what? Over what number? Over 150. Okay. Over 150. So I actually had SVT, lots of medications. I was stress induced, right? I was a leader in the hospital. Palpitations, couldn't feel my heart rate all of a sudden, tunnel vision, right? They call a code. Oh, it's Araceli. She did it again. Too much stress, working too much, something, right? Okay, lightheadedness, syncope, dyspnea, right? All of a sudden I couldn't feel my arms. I just literally went limp, okay? Not enough perfusion, okay? Now, they did vagal maneuvers. When I'm tunnel vision, I can't hear you. I heard everything muffled. Am I going to be able to cough or bear down? Probably not, right? Probably not. So adenosine is a medication that we give. It's a chemical defibrillator, okay? You have to have that crash cart near you at all times when you give this medication. We give it in 3 different instances. We give it in 2 different doses, 6 and 12, okay? What it does is it pretty much stops your heart, puts you in asystole, and then hopefully you come back in a normal sinus rhythm. Sometimes you don't, and that's why you need your crash cart, because now you're doing CPR. Yep, hopefully. That's that one, okay? And then an electrical cardioversion is actually where the patient is cardioverted by the cardiologist, okay? And then they pretty much, you know, externally, okay?
Because I'm on vagal maneuvers.
Uh-huh.
Ever come across an name called Valsalva maneuver?
Same thing.
Is it the same?
Uh-huh.
Okay.
Valsalva maneuvers or vagal maneuvers. It's just stimulating that vagus nerve. 150. Over 150. Super, super high. All right. Now, those were atrials. These are ventricular rhythm problems, okay? All right. Most common are the PVCs, preventricular contractions, early contractions of the ventricle. That's what that means. With these, the reason why it's serious is because if I have an early ventricular contraction, what didn't I have time to do?
Bill.
Fill the ventricle with blood, right? So I have one of those. Do I have a pulse with that PVC? No, you won't feel anything. It's literally an empty contraction. It has nothing associated to it. So you will not have perfusion. Okay? Got it? So when you have lots of PVCs in a row, what is that rhythm? It's lethal, but what is the rhythm specifically? Look at that first one. VTach, ventricular tachycardia, right? So if I have more than one PVC in a row, and we just said it has no perfusion, what happens to my patient? Right? They go unconscious. Guess what you're doing? You start CPR, and the best thing to do is early defibrillation, right? You're getting those pads on and you're trying to defibrillate. You're trying to restart that heart because the patient cannot stay in that rhythm or else you're never going to get them back. Okay?
We had a patient doing physical therapy and she went into VFib and collapsed. Then we had to start CPR.
Mm-hmm. Oh yeah, it's fast. It's fast.
We brought her back, but I don't know if she made it after that.
She's
She was
Hmm.
really old. She
She's-
lived?
Yeah, she's got a UTI.
No, but like, did she survive the CPR?
Mhm.
I
She had a
don't-
pacemaker.
So that probably helped too. It was probably trying to get her out of it as well.
Immediately took her to ICU.
Yeah. Oh yeah. Those patients, yeah. If you die, you go to ICU.
Woke her up. He's like, I need help.
So with PVCs, that's what that looks like. Those extra ventricular contractions. You see on the second strip, there's 4 of them in a row. That's 4 beats of VTach. Okay.
Does it matter whether it's inverted or
Mm-mm.
the QRST?
Mm-mm.
So sometimes I see.
It could be up, it could be down. That's more of a voltage, like an electrical thing. That's a cardiologist's job. Not that it doesn't matter, but that's the cardiologist's job. We'll let him tell us why that happened. Only he needs to know. Yeah, no, it has to do with the amplitude. It could be it could be as easy as where the leads are on the chest or the body morphology of the patient, whether they're skinny, thin, skinny or fat. There's a lot to that. So, but whether it's up or down, if they're there, bad problem. Yeah, you just don't want them there. Okay, so some of the things that can happen, or causes hypokalemia, right? High potassium or low potassium can cause it. Caffeine, alcohol, smoking, nicotine, right? Or if we have some comorbidities already with heart problems, heart disease. And the things that we would need to pretty much use, we don't use aminophylline that much anymore, but we use epi in the ICU setting, and then your patient would normally have DIG on their treatment plan if they have a history of going into lots of PVCs on a regular basis. Okay, so you'll probably see them be on DIG. DIG is a saving grace medication. It's the last in the bunch to be on. It's more for contractility of that left ventricle, but it's such an old drug. They're trying to take it off market just because there's really no benefit to it anymore. It's like, let me slap on another one because there's really nothing more to do. So
But you said aminophylline is not all used.
we rarely see it. We rarely see it.
So
Mhm.
it does matter.
Yeah, so we rarely see it in cardiac stuff. Now with DIG, what is something that we need to look out for if your patient's on DIG? For toxicity, what signs are we going to look for? Decreased DTRs, the halo, the yellow halo, okay?
Wait, what's going on?
It's going to be on NCLEX. So they'll start seeing a yellow halo, like a yellow haze, and like a halo effect, and that means that your DIG levels are too high.
Oh, I thought you meant they were gonna have
Oh, no, no, no.
yellow halo. I was like, are they involved?
How come so?
I was like, whoa, I did not hear that.
A yellow halo, like a haze. Okay, and then so these are some of the manifestations that they will experience, right? They're all signs of what? Decreased cardiac output, right? Okay, meaning that we're not getting enough perfusion. All right, so the big thing is we want to try to correct it, right? We want, if it's low potassium, we want to give potassium. If it's high potassium, we want to reduce the potassium. All right, so the lethal stuff. Ventricular tachycardia, this is that VTach I was talking about, right? No perfusion. We want to early defibrillate, get them out of it. Torsades de pointes, you see how it kind of looks like music? Okay, it's beautiful. But look at what we did over here. You see this big old box? That's what it looks like when we defibrillate you. Okay, it's a big old box. That's when I know, as a monitor tech, because of course I'm not seeing it, I'm watching it on the monitor, right? But I can tell your story by your rhythm, okay? That box, well, they just got shocked. Okay, all right. We're trying to restart it. We're trying to restart it. All right, so let's see. Chemical imbalance we talked about. Okay. Let's see. Again, we start with CPR, rapid defibrillation. So this is your treatment of choice, is we need to get that patient perfused until we can get them restarted, okay? VFib, now we don't have any ventricular conduction. We have no ventricle whatsoever. All we have is literally that ventricle is fibrillating. It's seizing up, okay? Now, this is shockable. But the moment that you see asystole, meaning there's not even any ounce of electrical conduction, is that shockable? No, right? What is another non-shockable rhythm? Not AFib. Oh, we said asystole was one. What's another one? There's only two. No, no, that's what we want to do. We want to shock that patient. No. PEA, pulseless electrical activity, meaning that we have our QRS, we have our P, we have our QRS, we have our T. The electrical conduction system is good. It's working. Why shock it? There's just no pulse for some reason, right? There's no, even though my electricity is working, there's still no circulation for some odd reason. No one really knows.
So when
PEA.
you checking the pulses.
Correct. Whenever a patient, you have a patient that's in distress, but only one at a time. Don't do both, because then you're going to really, decrease my perfusion to my brain, right? One at a time. Okay. You guys got to know that part for sure. PEA and asystole, non-shockable rhythms. Okay. Electrical activity, pulseless electrical activity, meaning I have my electrical activity, but no pulse associated to it. Okay. Here's that asystole, nothing, right? So have you ever seen, they come in all like Grey's Anatomy, all that, right? Oh, I think I see something. Let me shock it. They're like, let him go. He's dead. Oh, I think I see something.
Oh, in the pit, there was
Is
actually.
it on the pit? On the pit was one of them. And sure enough, they shock it, and there was something. They had just a little bit of spark of electricity to try to restart, right? It's kind of like your car battery, right? You can jump it if there's still some juice in there. But if it's dead, that thing ain't starting.
Oh, well, in the pit, he was doing contractions,
Mhm.
and that's what he was saying. He was like, no, I can keep it going.
Yeah.
And they're like, no, just let him go.
Okay, that must have been different. So it was on Grey's Anatomy for sure. No, The Resident. It was on The Resident. Okay. So again, that's what they're looking for. They're looking for any sign of electricity to be able to restart it. Okay. All right. Let's see. Pulseless electroactivity. So the electrical system's working, but the heart is not beating for some reason. Okay. More than likely, they're hypovolemic. It's after a trauma. There's no blood to circulate. Okay. There's no blood to circulate. All right, so we're going to do CPR. We're going to get them rehydrated, get some blood in them, and then we're going to hope to get a pulse after that. But we do not shock that, okay? This just tells you what cardioversion is on how we do it, right? It is definitely a controlled setting. You don't want to have to do it when you're by yourself because you're going to try to restart the heart, but what happens if it goes into asystole? Because it can do that too, right? Depending on the structure of the heart. So we don't want to do that. Defibrillation, you guys know that where the pads go, right? One up here, one over the heart or the bottom of the apex of the heart, okay? All right, if my patient is wet, what do I do first? Dry them off. If my patient is hairy, I don't have time for that. Get the pads, you explain it later. Wax them and explain it later, put on a new pair of pads, okay? A lot faster. You always have extras in your crash cart, all right? If it's a kiddo, where do those pads go? And I only have adult pads. One in the front, one in the back, okay? Very good, very good. Okie dokie. Pacemakers. Those usually go onto the left upper chest wall of the heart. It's in the, what we call a fat pocket. And then the lead goes into the ventricle, or it could be the atrium. There's different types of pacemakers. There's a pacemaker that's also a defibrillator, okay? So it just kind of depends on the patient on what they're going to insert, all right? Now, the big thing with this is you'll know when the patient has a pacemaker if it fires and it looks like a little spike, Okay, this one is an atrial pacemaker because it's on the P wave. I'm sorry. No, that's a ventricular pacemaker. So it's right before that QRS. It's going to make sure that it's going to give you a ventricular response. Okay. Sometimes we have AV pacemakers, atrial and ventricular, meaning there's a wire in the atrium and there's a wire in the ventricle. Okay.
What have the PRQ on
Mm-hmm.
that one?
So, okay, so that's a good question because on ventricular pacemakers, you may not have a P wave before every QRS. Mm-hmm. It just depends, yeah. Mm-hmm. Just because it's now an altered conduction system. It's something that, again, it's man-made, right? Okay, so it might look different. Okay, that's what that looks like. So it's under the skin. So big thing here is whenever these are placed, as a nurse, you have one job and one job only, okay? Checking the site and making sure that that patient's arm stays in that sling. We don't want them to try to brush their hair with that affected arm. We don't want them to do this, stretch, because what happens, those leads have not embedded in that heart muscle yet. You're going to pull the leads out and it's going to start firing in different places. Bad problem to have, okay? So we put the patient in the sling and we make sure that that arm does not move for a good 3 days. For 3 days. Not that bad. They can still shower and everything, but you need to just, when you take it off, give them a breather, whatever, but it can't rise above their head, okay? Lots of reinforcement teaching there, because if not, this thing will fire in the wrong spot, okay? And it could be lethal. All right. That tells you all your post-procedure stuff. So no MRIs. Why? There's a magnet in MRI. It's going to pop out of their chest, right? Now they still can travel, okay? Usually I just tell patients, make sure your card, you have a card that you walk around with. That card needs to make sure that it stays in your wallet and you just present it to TSI, right? And then, but you can go through usually those things, but some people choose not to, and TSI, as long as you have your card, you're fine, okay? They always say your cell phones, you should use the other side, electromagnetic waves, okay? You don't want it to start acting up, all right? They're so advanced now though, they're small, they're smaller, I should say. You still have patients that have the big old box, okay? So, and then they just interrogate it every 10 years and they replace the battery every 7 to 10 years, okay? Out of bed. Out of bed once stable, okay? So don't use it as an excuse that, oh no, I just had a pacemaker. No, you should start feeling better after a pacemaker, right? You should have enough heartbeat after a pacemaker, right? So you should be feeling good. Let's start walking. Don't leave them in the chair. Here are those arm restrictions, right? Looking for their skin, making sure that they're good, looking at their incisions, checking their neuromuscular function, okay? Questions? Was it good? All right. Thank you. Thank you so much. All right.
She's gonna be back in a couple weeks.
I will be back to give you guys